showed a year ago. Uh, Normal complete blood count, electrolytes, liver function test, and serum creatinine of 1.4 milligram per deciliter. Labs in your office remain. Sorry, the American question is raw metric system or mobile imperial system. You have seen it. Now, ma, the metalime you metric or one metalime you. The met chuba ma be ale, fortunately, milligram deciliter I don't yes, or familiar minute to worry. Pap smear and mammogram are current on exam. Blood pressure is 135 or 85 millimeter mercury. Pulse rate is 72 per minute. Weight 105 pounds. No edema, and the rest of the physical exam is remarkable. She just wants her medication refilled, and no further tests want to be done as results has been the same. So the questions are: you would, number one, so long as she keeps her health maintenance test her pap smear and mammogram current, agree with what she asked and see her again in 4 to 6 months. Number two, mention that her renal function is slightly abnormal, but not too bad, and recheck serum creatinine in a year time. Number three, tell her that she has renal failure and need further workup with a nephrologist. Number four, order for fractional excretion of sodium to determine between pre-renal versus renal origin. So if you forget, her serum creatinine was 1.4 milligram per deciliter, in case if you forget. And these are the 4 questions. And yep, now is the time to answer.
ဟုတ်ဆရာတို့ဆရာမတို့ကျွန်တော်ပို့ question လေး launch လုပ်လိုက်ပါပြီဆရာလည်းမြင်ရမှာထင်တယ်နော်ဆရာဟုတ်ကဲ့ခင်ဗျ
မြင်တယ် question မြင်ပါတယ်
ဟုတ်ကဲ့ပါဆရာဟုတ်ဆရာတို့ဆရာမတို့ဖြေပြီးလို့ရပါပြီဟုတ်ကဲ့ကျွန်တော်တို့ single choice question မှာပဲကျွန်တော်တို့ထုံးစံအတိုင်းကျွန်တော်တို့ဟို anonymous လုပ်ထားပါတယ်ဖြေရတဲ့သူဘယ်သူမှကျွန်တော်မမြင်ရပါဘူးခင်ဗျဟုတ်ကဲ့ပါကျေးဇူးပါဆရာတို့ဆရာမတို့ဟုတ်ဆရာဆရာမတို့ကျွန်တော်တို့အချင်းကိုငှက်ညာတော့အဖြစ်ပိုးလေးကိုပိတ်လိုက်ပါတော့မယ်ခင်ဗျဟုတ်ကျေးဇူးပါဆရာတို့ဆရာမ
ဟုတ်ကဲ့ဟို a minute and 30 seconds ဆိုလို့ရှိရင်တော်လောက်ဖြစ်မှာပါ
ဟုတ်ကဲ့
ကြည့်နေလေအဲ့တော့ထုတ်ပြီးတော့ဒါဆိုလို့ရှိရင်ဟိုဟာကို the answer ကိုနောက်တော့ at the end of the lecture မှာ diverge လုပ်ပါမယ်အခုတော့answer number 2 seem to have the highest response okay so I would like to proceed to the second question so ဒီဟာကိုဟိုပိုးဟို screen ကို minimize လုပ်လို့ရမလား
ဟုတ်ရပါတယ်ဆရာပိတ်လိုက်လဲရပါတယ်ဆရာဘက်ကနေဟုတ်ကျွန်တော်က launch လုပ်နေရမှာလို့ဟုတ်ကဲ့ပါဆရာ
okay now I will skip the answer which will go okay now it's a problem 2 32-year-old previously healthy carpenter is admitted with 4 days of high fever cough with rusty sputum and incessant vomiting on exam he looks toxic weight is 196 pounds, typical Westerner. Temperature 104, pulse rate 120, looks a little tachycardic, respiratory rate 24, and blood pressure is 90 over 45 millimeter mercury. Auscultation showed rails in lower lung fee on both sides. Chest X-ray showed bilateral lower lobe infiltrates, white cell count, as you can see, elevated 24,000. Hemoglobin is 14.5 gram per deciliter, platelets 380, blood urea nitrogen BUN 34, creatinine 1.5 milligram per deciliter, and intravenous ceftriaxone and gentamicin was started. The next morning, it is noted that urine output was low overnight, vitals remained about the same, and blood cultures came back gram-positive cocci growing. BUN is now 80, which has gone up from 34, and creatinine is 3.1, which has gone up from 1.5 yesterday. Urinalysis showed specific gravity of 1.028, ketones positive, blood negative, sugar negative, protein trace, hyaline cast, RBC negative, WBC negative or 0. Your diagnosis and further management will be, so single response answer, only one of them will be correct. Number 1, it is aminoglycoside nephrotoxicity and stop gentamicin. Number 2, post-streptococcus glomerulonephritis, check complement levels and continue current antibiotics for now. Number 3, order 24-hour urine protein and creatinine clearance. Number 4, give volume resuscitation by IV fluid, normal saline at 200 cc per hour. Number 5, this is sepsis-induced acute tubular necrosis and prepare for dialysis in near future. And please answer choosing one of the above 5. You may start the poll question.
ဟုတ်ဆရာတို့ဆရာမတို့ pool လေး launch လုပ်လိုက်ပါပြီဗျဟုတ်
ဟုတ်တယ်နော်10မိနစ်ခွဲအချိန်ပေးပါမယ်10မိနစ်ခွဲအတွင်းမှာပြည့်အောင်လေးဖြည့်ပေးပါ
ဟုတ်ဆရာတို့ဆရာမတို့ကျွန်တော် pool လေးကိုအန်လုပ်လိုက်ပါတော့မယ်နော်ဟုတ်ကဲ့ပါ
Okay, hope majority of them think this is aminoglycoside nephrotoxicity. Okay, we will discuss about that. And we will go to problem 3. This is the last one. A 20-year-old female student who is a member of college track and field team presents to the emergency room after a track meet with flu-like symptoms, sore throat, and temperature of 100 degrees Fahrenheit. Urinalysis is normal except 3+ protein. You would, number 1, treat as post-infectious glomerulonephritis. Number 2, collect, which by that means morning and evening, AM and PM 24 urine collection for protein. Number 3, collect 24 urine protein and creatinine clearance to determine the severity of the condition. Number 4, retest urinalysis once acute illness is over. Number 5, proceed with a kidney biopsy, clinically suspecting minimal change glomerular diseases. So please pick one correct answer which you feel is the one. Young female college track and field athletic team member presenting with fever, short-term fever following a track meet and has some protein in the urine. So in case if the poll question is covering the stem.
ဟုတ်ဆရာတို့ဆရာမတို့ကျွန်တော် pool လေးကိုအန်လိုက်ပါတော့မယ်နော်10မိနစ်ခွဲပြည့်ပြီဆိုတော့ဟုတ်ကဲ့ပါ
So this is the last of the questions. So let me go back to the very beginning of the lecture and let's start the actual lecture. So first of all ကျွန်တော်ကိုဒီ nephrology နဲ့ပတ်သက်ပြီးတော့ COVID related nephrology section 2 lecture လောက်ပေးပါလို့ကျွန်တော်ပြောတော့လေကျွန်တော်ကြည့်လိုက်တော့ COVID တခုတည်းနဲ့ဆိုလို့ရှိရင် there's not much to cover. COVID က to be honest, it's infectious disease process, more of an infectious disease process. It is more of a pulmonary medicine process or even internal medicine. For nephrology, yes, we see it a lot, but a lot of them are due to acute kidney injury, not because of direct COVID virus infection to the kidney, but related to hypotension, sepsis, due to the side effect of other medication that is used for treatment of COVID, shock, those kind of things. So essentially, we will have to know about the acute kidney injury. So that's why I think COVID တခုတည်းကိုပဲပြောမယ်ဆိုရင်5မိနစ်နဲ့ပဲပြီးသွားမယ်အဲ့တော့ I decided that I would cover acute kidney injury or full-term acute renal failure ပေါ့အဲ့ခါမှာဆိုလို့ရှိရင် again what I noticed is that ဒီအခုနောက်ပိုင်းမှာပေါ့နော်ဆရာတို့ခေတ်နဲ့ရှင်လို့ရှိရင်ဒီ lecture ဆိုတာ reading material is quite widely available. What most student needs is a concept, how to tackle a problem, to know the theoretical understanding behind it. ဆရာတို့ခေတ်ကလို့မဟုတ်ဘူးဆရာတို့ခေတ်ကဆိုလို့ရှိရင်ဟာ corporation 9ကုန်သွယ်ရေးကိုက textbook ဆိုလို့ရှိရင်ကျောင်းသား300ရှိတဲ့ C1 မှာဆိုလို့ရှိရင်နှစ်ကိုအုပ်20လောက်ပဲသွင်းတယ်ကျောင်းသားတွေမဲဖောက်ပြီး20လောက်ပဲကံကောင်းတဲ့လူပဲရတယ်အဲ့တော့ဆရာတွေကပုတ်ပြီးတဲ့ handout လို့ခေါ်တဲ့ lecture တွေကိုဆိုလို့ရှိရင်တဲတန်လိုက်ပြီးတော့ရအောင်ယူရတယ်ဆရာတွေပြောရင်လိုက်ရေးရတယ်အခုခေတ်မှာအဲ့ဒါတွေမလိုတော့ဘူး YouTube ပေါ်မှာရှိတယ်ဟလာ up to date ရှိတယ် every information is available. But what you need is to get the concept, theoretical background understanding, and once you understand that, you can go read up anytime. So I don't see the acute kidney injury go ခြုံပြီးပြောမယ်ဒီ acute kidney injury အကြောင်းကို work up ဘယ်လို handle လုပ်မလဲကို processing လုပ်မလဲဆိုတော့နားလည်သွားပြီဆိုလို့ရှိရင် COVID-19 ကြောင့်ရတဲ့ acute kidney injury acute renal failure ပဲလာany other type of acute kidney injury may it be hemorrhagic shock may it be septic shock ဘာတွေပဲလာအဲ့တော့COVID တစ်ခုတည်းတော့ဟုတ်ချင်မှဟုတ်မယ် but I hope that it will be useful. Likewise, my second lecture on day 2 tomorrow, I'm also thinking to give a few theoretical background on the volume disorders and how diuretics are used, what is the causes of diuretic resistant body. ဘာဖြစ်လို့လဲဆိုတော့ခုနပြောသလိုပဲCOVID နဲ့ပတ်သက်တဲ့ nephrology section ပဲပေးပါဆိုလို့ရှိရင်ဘာမှသိမရှိဘူး so I want to make it useful for you guys. So just a little brief background introduction just to tell who am I or what am I is so ဆရာက87ကတစ်ကပြီးတယ်88မှာအောက်စာချင်းပြီးတယ်89မှာမာပြထွက်လာပြီးတော့အရင်အမေရိကန်အင်္ဂလန်ကိုသွားပြီးတော့ MRCP လုပ်တယ်3နှစ်4နှစ်လောက်လုပ်ပြီးတော့အမေရိကကို93ကကူးလာတယ်ပေါ့လေအဲ့ထဲကနေပြီးတော့ residency ပြန်လုပ်ပေါ့အမေရိက England training ကို direct recognize မလုပ်တော့ MRCP ပြီးလဲ residency ပြန်လုပ်ရတယ်ပြီးတော့ specialist လုပ်ချင်တာနဲ့ nephrology fellowship လုပ်ပြီးတော့ nephrologist အနေနဲ့ full fledged nephrologist အနေနဲ့2001မှာ training ပြီးပြီးတော့ nephrologist လုပ်နေတာတော့20ရှိပြီပေါ့လေjust for a side note ပေါ့နော်အခုဒီအရေးခင်းဒီ spring revolution တွေဦးတော်လိုင်းကြီးဖြစ်နေတော့အဲ့တော့ဆရာတို့အပေါ်တန်းက86 batch ကဆိုရင်တော့အခုဟလာကျမကြီးဝင်ကြီးလုပ်နေတဲ့ဒေါက်တာတက်ခိုင်ဝင်းပေါ့ but likewise 86 batch ကပဲဆရာတို့အပေါ်တန်းဆေးနှစ်ကကြတော့ဆရာဇော်ဝေစိုးပေါ့87 batch ကတော့ဆရာတို့စစ်တစ်က classmate တငယ်ချင်းကတော့အရင်စိတ်မန်းမှာ rector လုပ်သွားတဲ့ဟိုခမောင်လွင်ပေါ့အခုတော့သူက CDM နေနဲ့သွားနေပြီပေါ့နော် likewise 87 batch ပဲဒါပေမဲ့စိတ်ဟိုမှာ MC2 မှာ rector လုပ်နေတဲ့ဆရာအေးထွန်းသူကတော့ MC2 อ่ะပေါ့လေ anyway this is just a little FYI side note. Okay, so before we go over with the acute kidney injury, I would like to quickly refresh your memory from second MV on anatomy, but you need to know this. So this is, the kidney, this is the efferent arteriole. It will divide into capillary loop, reconverge in the efferent arteriole, and then we'll get the true capillary system and then turn into a vein. And then this is engulfed by the Bowman capsule. This is the Bowman capsule. From Bowman capsule, this is the proximal convoluted tubule, loop of Henle, descending link, ascending link. This is the convoluted tubule, collecting duct, and then collecting tubules. And all these areas, these tubules are lined by renal epithelial cells, which has selective function, which we'll go over it. So we need to know this anatomy a little bit. And this is a little bit amplification of a glomerulus. Efferent arteriole divide and branch and form into capillary loop and remerge as efferent arteriole. And this capillary loop is engulfed by the Bowman capsule, which has two cell layers. One is the parietal epithelial cell. This is the visceral epithelial cell. So if you look at the glomerular basement membrane barrier that plasma has to filter or go across to be here at the proximal convoluted tubule, so it passes through 3 cell layers: endothelium of the capillary endothelium, the dotted, not the dotted, the solid line, which is the basement membrane, and this other outer layer is the visceral epithelium of the Bowman capsule. So I don't tweet it, the blood hemorrhage plasma, glomerular basement membrane, the proximal convoluted tubule level, the composition, the composition is exactly remain the same as plasma. Sodium, same as plasma, maybe 135, potassium, maybe 4, 5, same as plasma. The only thing that is lacking is albumin and plasma protein because the glomerular basement membrane barrier doesn't allow the passage of the albumin and or other larger molecule. But think of it from this segment, proximal convoluted tubule, ultrafiltrate composition plasma electrolyte, when light to light, so light to light, load light, at the end of this is the proximal convoluted tubule along that ultrafiltrate which passes along during the process, electrolyte, when light to light, loaded away. By the time urine yellow pillari, when it come out as urine here, the composition is totally different. As you can see, urine has high concentration of urea, creatinine. They have very little electrolytes such as like sodium, but it will have high electrolytes like potassium. So that's what the glomerulus or the nephron works. And we need to remember that basic concept to understand workup of acute kidney injury and other things. The kidney disorder, the renal diseases, you can broadly consider it's whether the main pathology is either in glomerulus, such as like many glomerulonephritis, post-infectious, rapidly proliferative glomerulonephritis, or the lesion is in tubular. The name acute tubular necrosis stands for, as the name implies, that necrosis of the tubular epithelial cells. Or in the interstitium, the pathology is in the interstitial cells, or they are actually inside the vascular, such as like thrombosis, microangiopathic hemolytic anemia. But in the end, when the disease process has protracted for long enough time, everything is scarred out and fibrotic. At that point, if you go and do a kidney biopsy, the only thing that you would find is a lot of scarring. Quickly assessing the renal function, we all know that creatinine is used as assessment of the renal function. The reason is creatinine is a kind of like the ideal substance. It's kind of ideal, but not ideal. The renal function, glomerular filtration, renal blood flow assess solution. If you choose a molecule which is completely 100% filtered at the glomerulus level, and then it is neither secrete lemon reabsorb lemon urine ma ti time pian pi ro excrete လုပ်မယ်ဆိုလို့ရှိရင် clearance of that substance will exactly be the same as glomerular filtration. So creatinine almost fulfill that, not 100%, but among the available easily measurable substances, creatinine almost fulfill it. The reason I say almost is because at the once the creatinine start to get high, once the chronic kidney disease develops, the magnitude or the component of creatinine secreted through the renal tubular epithelial cells, they are နည်းနည်းပိုပြီးများလာတော့ creatinine နဲ့ပဲကြည့်မယ်ဆိုလို့ရှိရင် there can be a little bit overestimation of the GFR. So we can see the relationship that serum creatinine inversely is related to GFR. GFR နည်းလေ creatinine တက်လေဖြစ်မယ်။အဲ့ဒါတက်မှနည်းနည်းပိုပြီးတိကျကျင်တယ်ဆိုလို့ရှိရင် instead of using the raw creatinine, because of all these, we can calculate the creatinine clearance. လွန်ခဲ့တဲ့နှစ်20ဆရာတို့ဒီ nephrology fellowship စတဲ့အချိန်မှာဆိုရင် GFR calculate မလုပ်သေးဘူးဘာလို့လဲဆိုတော့ GFR calculation က this mathematical formula without any iPhone တွေ smartphone တွေဘာညာမရှိသေးတဲ့ခါမှာဆိုလို့ရှိရင်ကိုယ့်အကို creatinine calculate clearance ကိုကိုနဲ့ထားပြီးတော့တွဲရတယ်ဘာလို့လဲဆိုတော့ 140 minus H multiplied by weight then divided by serum creatinine 72. So compared to creatinine clearance ကနည်းနည်းလေးပိုပြီး sensitive ဖြစ်တယ် accurate ဖြစ်တယ် and lately in the last 10 years မှာတော့ glomerular filtration rate ကို using this mathematical formula we can calculate it, which shows more accuracy. So the reason we do not want to use creatinine as the sole marker or assessment for renal function is creatinine comes from the breakdown of muscle protein creatinine. So someone's raw creatinine level has somewhat dependency on the body mass. So example like နေ့တိုင်း weight တွေမပြီးတော့ပေါင်180 200လောက်ရှိတဲ့အရက်6ပေလောက်ရှိတဲ့เนาะတကယ် waiter ကြီးတယောက်ကို weight lifter ပြောတာ weight lifter တယောက်ရဲ့ blood creatinine ကိုသွားတိုင်းရင်သူ creatinine 1.2 1.3 milligram per deciliter, and when you go and experimentally measure the GFR you will find out that that creatinine will be compatible with GFR 100 and normal. On the other hand အသက်ကြီးကြီးအသက်85နှစ်လောက်ရှိတဲ့အမေကိုအဖွားကိုတယောက်ပေါင်က80လောက်ပဲရှိတယ်အယိုးပြိုင်ပြိုင်ပဲရှိတယ်သူ့ရဲ့ blood ကို creatinine သွားတိုင်းလို့ရှိရင်တကယ် normal GFR 100 ရှိမယ်ဆိုရင်သူ့ရဲ့ creatinine က 0.6 0.7 milligram per deciliter လောက်ပဲရှိရမယ်သူ့အတွက် creatinine 1.3 could be that is reflective of renal disease. And the other thing is that creatinine can be a little bit insensitive. I'll show it in the next graph. And like I've just said earlier, in case of renal failure, there is a little bit extra secretion of creatinine through the tubular cells, and such that looking at creatinine alone may overestimate kidney. And this graph illustrates, this is a famous graph that came out in the 60s, published in the New England Journal. This is not research. This is just a graph showing the correlation. What it shows is that on the x-axis, you have the glomerular filtration rate starting from 120, and on the y-axis, you have the serum creatinine. And as you can see, as the GFR decline, creatinine start to go up high. Compared to GFR 80, if you have GFR 25, creatinine will be 3, GFR 80, creatinine will be 1. And there are 3 peculiarities of this graph. By the way, and true GFR is represented by the solid line, and creatinine clearance is represented by the dotted line. So there are 3 characteristics of this nomogram. This is a normal finding. They look at large population of people. At the beginning of the drop in GFR, for example, like, look, if you have declining GFR from 120 to 80 millimeter mercury, how much creatinine would go up? If you have 120 GFR, the creatinine may be about, say, 0.8. And if you have 80, which is almost a third of the GFR dropped, but creatinine goes up only by 0.1. So that's the number 1 fact. At the beginning of the renal failure, looking at the raw creatinine can be misleading because it is insensitive. Creatinine လေး ဘယ်လောက်တက်သွားလို့လဲ 0.6 ကနေ 0.8 လောက်တက်တာများဘာဖြစ်လို့လဲဆိုပြီးတော့မြင်စရာရှိတယ်ဒါပေမဲ့ that might represent GFR drop by about 20%. At the later stages, the curve becomes a little steeper, so that's not a problem. And number 2 finding, if creatinine clearance and GFR are exactly the same, they would be overlapped all the time. They are overlapped here, but as the GFR start to decline, creatinine clearance start to overestimate the GFR. For example, like if you have creatinine of 3, if you just go by GFR, it may indicate GFR may be about, say, 20. But if you go by creatinine clearance, it might suggest that GFR will be still about 28. The reason is because kidney function decline ဖြစ်လာတဲ့ chronic renal failure ဖြစ်လာတဲ့အချိန်မှာ creatinine glomerulus ကနေglomerulus ကနေပြီးတော့ glomerulus ကနေဒီလို filtrate လုပ်ပြီးတော့ဒီတိုင်းလုံးဝ 100% ထွက်သွားတာမဟုတ်ဘဲနဲ့ဒီ along the tubular cell တွေထဲမှာနည်းနည်း secrete လုပ်ခံရတယ်အဲ့လိုမျိုး secrete လုပ်ခံရတဲ့ကြည့်လိုက်လို့ရှိရင် clearance ကတိတ်ကောင်းနေထင်ပြီးတော့ there's overestimation of the kidney function. So that's the second concept. GFR and creatinine may overlap and can be used interchangeably at the beginning, but as the kidney function declines, the creatinine clearance tend to overestimate the stage of the kidney disease. And the third concept is, if you look at individual A, B, and C, D, this is between individual A and B. The individual A has a serum creatinine of 3, and individual B has a serum creatinine of 1, but their GFRs are totally different for individual B. I'm sorry, I said other way around. Individual A and B, they have the same GFR, suppose like about 45, but for individual A, that GFR is reflected by creatinine of, say, 2.5. For individual B, this GFR is reflected by creatinine of 1. So that represent the earlier example that I mentioned. Creatinine to our solution, one solution, GFR, sorry, creatinine high people GFR still okay, whereas the other small lady, that high creatinine, GFR will be very low. It is reflected much better here. So creatinine 2 people individual C GFR 40 လောက်ရှိအောင်မယ် individual B D GFR 20 လောက်ပဲရှိတော့မယ် individual D ဆိုတာဒါဆိုလို့ရှိရင်အပွားကြီးကိုလေးတယောက်ဖြစ်ပြီးတော့ individual C တကယ်ဝိမာနေတဲ့လူငယ်လေးတယောက်ပေါ့ that's why we start to not to rely purely on creatinine to assess the renal function. And other thing is that there are other non-renal factor kidney failure ကြောင့်မဟုတ်ဘဲနဲ့ BUN creatinine ကိုပြောင်းလဲနိုင်တဲ့ factors တွေလည်းရှိသေးတယ် just a quick refresher, because urea is synthesized or produced in the liver through the urea cycle, right? So any type of liver disease which impair the synthesis of urea, not surprisingly, you will have low urea level. So, for example, like hepatic failure, low protein intake, and due to SIADH, when the blood is diluted, not surprisingly, urea level will be artificially low. to the given degree of renal failure. On the other hand, there are conditions where urea will be disproportionately high out of proportion to the degree of renal failure. UN ကအရန်မြင့်နေမယ်100လောက်ရှိပဲဒါပေမဲ့တကယ်တော့သူ့မှာအဲ့လောက်ဆိုးတဲ့ renal failure မရှိဘူး so certain conditions are pre-renal azotemia because of the pure dehydration, upper GI bleed because of the GI bleed, the blood is leaked inside the stomach, which will be broken down and digested by the hydrochloric acid, and that protein breakdown products are absorbed through the GI tract, so artificially leading to elevated UN level. Steroids by virtue of catabolism, hyperalimentation, which is a lot of amino acids, hyperalimentation. If you use too much hyperalimentation, which contains a lot of protein, your urea will be artificially inflated compared to the given degree of renal failure. The same with creatinine. If you have rhabdomyolysis, damage of the muscle, which release the muscle protein, so there will be serum creatinine will be alarmingly high, like 4-5 milligram per deciliter. GFR and the kidney function maybe not as bad as it looks. And if the creatinine secretion is blocked by certain medication, trimethoprim, cimetidine, then the creatinine stay in the blood, so creatinine will be artificially elevated. Chemical interference is due to laboratory techniques in measuring the creatinine. Those are less of an issue nowadays with the modern day equipment. And likewise, when you have reduced muscle mass, you may have misleadingly low creatinine out of response to the out of respect to the degree of renal failure. A quick, useful assessment of the kidney function because ဗမာပြည်မှာဆိုလို့ရှိရင် the field level မှာဘယ်သူမှကျွန်တော်တို့လည်းဒီဘဝတက်လာတာပဲတခြား rapid electrolyte testing တို့ blood gas testing တို့ urine sodium level တို့ဘာတွေမလုပ်နိုင်ဘူးဆိုရင် at least hopefully urinalysis can be done. All you need is microscope and centrifuge machine. Urinalysis ma ba pa le, one macroscopic evaluation. You look at whether there is cross blood or this or things like that. And the second is chemical evaluation. The chemical dipstick strip urinal dip load there, color change whether you can tell whether that urine contains protein versus glucose versus ketone nitrates can be done. And the third is microscopic evaluation. You need a microscope. During centrifuge 3 to 5 minutes spin low. Sediment go ipalina salt power slide for Martin can be a solution low power 10 solution crystal in high power 40 times the solution cells in cell shila, car simla, crystal shimla, you can get at least some rough idea. So this is a very basic urinalysis. Nephrology fellow manamya urinalysis ko pian sa lo ware sei jaw ma lok lo mlo lo sia ro Brahma nephrology fellowship ဝင်သွားပြီဆိုလို့ရှိရင်အကုန်လုံးပထမ2ပတ်လောက်ကဒါကို urinalysis ကိုအရင်စပြီးတော့လုပ်တော့လုပ်ခဲ့ရတယ် So here are a few representative samples of the urinalysis. This is normal RBCs. Balu RBC lo call it. There is no nucleus, right? This is the RBC size, and they are normal RBC. By saying normal, I mean that it is not deformed or deranged. So, balu hamyo ma twi mle so yin da ga bladder cancer lo hamyo, bleed phit de hamyo, maybe kidney stone. What I'm trying to say is that RBCs that has passed through from the kidney, glomerulus level pass through glomerular filtration barrier ဖြတ်လာတဲ့ဟာမှာဆိုရင်ဘလို့မှသူက normal shape မရှိတော့ဘူး either they may be in the form of cast or deformed ဖြစ်နေမယ် For example, like IgA nephropathy, IgA ဆိုတာ glomerulonephritis, so အဲ့မှာရတဲ့ RBC တွေဆိုလို့ရှိရင် they are quite deformed ဖြစ်နေတယ်ပြလိုက်လို့ရှိရင်ပုံစံဒါက RBC မဟုတ်ဘူးဒါတွေကအထဲမှာ granule တွေရှိတယ်เนาะဒီမှာဒါတွေက deformed ဖြစ်နေတဲ့ RBC တွေအဲ့ဒီဟာတွေက compared to ဒီမှာ clear cut မုံလက်ကောက်လိုဟာမျိုး There solution many WBCs ဘာကြောင့် WBC လဲဒီမှာဆိုရင် multi lobe ဟလာ neutrophil တို့ဘာလို့မှာဆိုလို့ရှိရင် bilobe trilobe ရှိတဲ့ eosinophil တို့မှာဆိုလို့ရှိရင်ဒါ multi lobe nucleus ရှိတဲ့ RBC နဲ့ကွာတော့ RBC လည်းပိုကြီးတယ် These are budding yeast, and on the other hand these are the renal tubular epithelial cell much larger than the white blood cell. And oftentimes they may have one nucleus, sometimes they don't, because presence of small amount of renal tubular epithelial cells is pretty common or considered as normal, because renal tubular epithelial cells are သူ့ရဲ့ lifespan ကုန်လို့ရှိရင် shred ဖြစ်တာပဲဆိုတော့ it's non-specific. This is muddy brown cast and debris. Muddy brown cast, we call it muddy brown because it looked like that, ရွှံ့ရောင်လိုမျိုးဖြစ်နေတယ်. Muddy brown cast is made up of necrotized renal tubular epithelial cells. Renal tubular epithelial cells တွေသေသွားပြီးတော့ necrotize ဖြစ်ပြီးတော့ Tom phosphor protein နဲ့ပေါင်းပြီးတော့ dirty looking cast တွေနဲ့ ဒါဆိုလို့ရှိရင် it's a characteristic feature of acute tubular necrosis. This is the damage of tubular epithelial cells. Tubular cell cast that can be found in normal situation. You can still see the outlines of the renal tubular epithelial cells. Outline မပြတ်သေးဘူး ဒါပေမဲ့သူတို့က cast နေနဲ့ရှိနေတယ် ဒီလိုမျိုးအလုံးချင်းမဟုတ်ဘဲနဲ့ cast နေနဲ့ရှိနေတာ ဘာဖြစ်လို့လဲဆိုတော့ဒီ tubule တွေမှာရှိတဲ့ normally existing Tom phosphor protein နဲ့ပေါင်းပြီးတော့ဒီလိုမျိုး cylindrical cast နဲ့ထွက်လာတယ် so they can be normal. This is the RBC cast, made up of RBC. They are clumped together. So if you are looking for things like rapidly proliferative glomerulonephritis, lupus nephritis, Goodpasture, Wegener, Anchor, all of those where you have RBC cast, this is what the RBC cast will be. They are lumped together. This is the nephrotic syndrome of renal tubular epithelial cell. Because in nephrotic syndrome, there is so much fat and protein in the urine, some of which are reabsorbed by the renal tubular epithelial cell. And when those fat-laden renal tubular epithelial cells shred, you may appear as lipid-laden cast. And this is just to emphasize the lipid content in a polarized light. These are some crystals in the urine, hexagonal cystine crystals, envelope-shaped oxalic crystals. These are envelope-shaped, these are cystine, and then this is coffin-shaped triple phosphate crystals. So as I have said earlier, cast indicate that it comes from kidney parenchyma level, not from ureter, not from bladder, those kind of things. RBC casts, typically in the glomerulonephritis, the WBC cast, if you have higher up infection like pyelonephritis, you may see the WBC cast, but in the lower urinary tract infection like cystitis, you may just see the WBCs. Fatty cast, we talked about it. Tubular cast may be seen occasionally in ATN, but typical finding is muddy brown cast. Urinalysis, we can divide into nephritic pattern and nephrotic pattern. As the name nephritic implies, it means an inflammation. So we may call it as active sediment. By that mean, on dipstick, you will find blood dipstick that blood 2+ protein microscopic exam not only there are RBC cast WBC cast whereas nephrotic patterns inflammation ဖြစ်လို့မဟုတ်ဘူး the glomerular basement membrane leaky ဖြစ်ပြီးတော့ minimal change disease, membranous change disease, FSGS အဲ့လိုမျိုးတွေမှာ protein တွေ leak ဖြစ်တဲ့အခါမှာဆိုရင် of course when you tested the urine with the dipstick, you will find protein 2 to 3+. On microscopy, you will not find those RBCs or the WBC. Mostly you will find overfed body, hairline cast. So by roughly dividing into nephritic and nephrotic patterns, sometimes you can think of which direction you should lead in further pursuing the workup. Whereas in pre-renal, totally dehydrated state, in that kind of situation, urine may be highly concentrated. Tubular cell, they are shred မလုပ်သေးဘူးဆိုတဲ့အခါမှာဆိုလို့ရှိရင် all you will find is bland urinalysis, high BUN creatinine, and very little sodium in there. Imaging studies, I will not go very much in detail. After lecture မှာဆိုလို့ရှိရင်လည်းဒါတွေဟိုဆရာ PowerPoint ကိုဟိုဟာတွေကို ICAP ကိုပေးမှာဆိုတော့လေပြန်ပြီးတော့ copy ရမှာပါ Normal kidney size is roughly about the 3.5 times of the vertebra. Left may be a little larger. Intravenous pyelogram nowadays is mostly being supplanted by CT scan. KUB is very rarely useful. Ultrasound best to assess the kidney size, hydronephrosis, but no risk for radiation exposure, very cheap. And nowadays we have even bedside ultrasound, so we can quickly do it yourself. We don't even have to send to radiology. Of course, you need to know how to read the ultrasound though. CAT scan, we can identify more detailed cysts and contents. magnetic resonance angiogram for renal artery stenosis. This is old-fashioned angiogram where you inject the dye into the artery and take the picture. It's gold standard for renal artery stenosis, but sometimes look for any other highly vascular tumors. If you want to see whether the kidney has a lot of WBC infiltrated, you can use Gallium scan. Kidney biopsy is a gold standard if the diagnosis is unclear, but of course there are side effects, this is the stated side effect. About 1 in 10 kidney biopsy, you will have a little bit of hematuria for 24 hours or so, but nothing needed. About 1 in 100, the hematuria is heavy enough that you may end up having had to give blood transfusion. And in about 1 in 1,000, the hematuria and the bleeding is persistent to the point that you may even have to perform a nephrectomy to stop the bleeding. So those are the risks. So kidney biopsy is not a risk-free procedure. Sometimes we do it, but we do not do it for acute tubular necrosis to diagnose. So by understanding this background workup, how to assess the kidney function, I would proceed to acute renal failure, or the newer term acute kidney injury. Acute kidney textbook အဟောင်းနေကြည့်မယ်ဆိုရင်တော့ acute renal failure နဲ့လွန်ခဲ့တဲ့နောက်ပိုင်း10နှစ်လောက်ကထွက်လာတဲ့ textbook တွေဆို acute kidney injury ဆိုတာဖြစ်မယ်. The reason I spend time on other aspect of acute kidney injury, I can finish in 2 slides. So management of acute kidney injury, you can memorize just these 3 sentences. There is nothing more to it. လွန်ခဲ့တဲ့နှစ်40အတွင်းမှာလည်းဒါတဲ့ပို့ပြီးမတက်လာဘူးအဲ့တော့ identifying the culprit and correct or remove it, and provide supportive care and being cognizant of when to intervene with renal replacement therapy, which is dialysis. That's all. That's in a nutshell. ဆရာတို့နှစ်40လောက် nephrology တွင်းမှာလည်းဘာမှထပ်ပြီးပို့မထူးလာဘူး The key is ဘာကြောင့် kidney fail ဖြစ်ရလဲဆိုတော့ identify low and then either correct or remove it. If it is due to obstructive uropathy, correct the obstruction, remove the stone, remove the enlarged prostate. If it is due to hemorrhagic shock, give blood transfusion, bring up the blood pressure. If it is due to certain toxic substances like antibiotics, stop the antibiotics. If it is due to dehydration, give ringalactate, normal saline, so and so forth. And after identifying and correcting the culprit, the next step is you need to be closely monitoring the patient to see when we might have to intervene with dialysis. Now, beware that dialysis is a replacement procedure. It's not a curative procedure. Dialysis ka piatသွားတဲ့ kidney ကိုဘာမှသွားပြီးကောင်းအောင်လုပ်နိုင်တာမဟုတ်ဘူး What it does is that buys time. It allow us to fix the problem that went wrong. Okay, so dialysis ဆိုတာနဲ့ dialysis က kidney ကိုဘာကောင်းတာမဟုတ်ဘူးအဲ့တော့ဟိုက kidney ပြန်ကောင်းအောင်လုပ်ဆရာရှိရလုပ်အောင်မယ် but of course dialysis is useful. It can correct the electrolyte abnormalities, maintain the body in a stable state so that we buy time and fix the other things. Acute renal failure and acute kidney injury it's more for research purposes. Acute renal failure definition is still fine for day-by-day purposes because acute renal failure, this definition is still stand true. What it means by acute renal failure, syndrome of sudden deterioration in renal function resulting in the inability of kidneys to regulate normal homeostasis. And of course, clinical hallmark is CB12, oliguria, and azotemia, BUN creatinine electrolytes is there. But this is very non-specific, hard to stage, which is okay for clinician. But the problem comes into place when we start to publish papers and try to compare the data and the outcomes. One hospital may say that, okay, we have so-and-so acute renal failure patient and we treated with this therapy and we have so-and-so outcome. Another hospital say that, no, we use that treatment and instead we have that outcome. But if we can't have a common ground or basic understanding how to stage or define the renal failure, all the therapies and the treatments are moot. So we come to an agreement that we have to be more specific in staging it, more for research and publication purposes. So you can read it. So you don't need to memorize the stages because that's probably is not going to be helpful in deciding whether you dialyze or you don't dialyze or things like that. But for your knowledge, it depends on either how high the creatinine goes up or how low the urine output becomes. And you need to fulfill only one criteria. You do not need to fulfill both criteria. It's one or the either. and the rise in serum creatinine has to be within 48 hours. So for example, like if a patient's serum creatinine has gone up by 1.5 to 2.4 from the baseline, or if you have absolute rise in serum creatinine of 0.3 milligram per deciliter, it will be staged at AKIN stage 1. Whereas if you don't have creatinine, but you have oliguria lasting for 6 hours at least, then it will be stage 1. And as it goes on, stage 2, stage 3 are higher and higher creatinine, or longer and longer and more intense oliguria. Just a quick refresher, again, this can be read in many textbooks. So classically, when we look at the etiology for acute kidney injury, we divide it into pre-renal causes versus renal causes versus post-renal causes. And if you must look at it categorically, the pre-renal causes constitute almost 2/3 of it. And pre-renal can be truly from reduced effective circulatory volume, such as like hemorrhagic shock, dehydration, or sometimes it may be functional, such as in severe CHF with poor cardiac output. When you have poor cardiac output, you may have edema and you may look bloated, but what it is lacking is the effective pumping of the heart, and likewise lack of effective perfusion pressure head to the kidney. So that's why the kidneys interpret as, okay, no blood is coming, I must be dehydrated. 20 to 30% of causes are from renal, and out of that 20 to 30%, majority of the causes are from acute tubular necrosis. Very few are from glomerular causes, such as like rapidly proliferative glomerulonephritis, less than 5% of this 20 to 30%, or interstitial nephritis, which is due to drug allergic reaction, or the vessels itself, like vasculitis, hemolytic uremic syndrome, microangiopathies, and other things. So majority of the causes are from acute tubular necrosis, and out of that acute tubular necrosis, yet again, ischemia contribute majority or the bulk of the reason why tubular cells get necrotized. Toxins contribute only about 20 to 30%. Toxins such as like myoglobin, aminoglycoside, they can cause direct damage to the tubular cell, whereas ischemia is the main problem. And of course, you can have post-renal obstruction like in PPH. So this is the little cartoon of what the renal tubular epithelial cell, we keep on saying, ATN, ATN. So what is ATN? And this is the renal tubular epithelial cell. It is necrotization of renal tubular epithelial cell. Why it is important? Like I have explained earlier in the very first diagram, the ultrafiltrate that has passed through the glomerular basement membrane barrier right at the beginning of the proximal convoluted tubule, the composition is entirely the same as plasma. The only thing that is lacking is the proteins. From that stage, a lot of the electrolytes either get reabsorbed or excreted, and they can do it against the concentration gradient because the renal tubular epithelial cells have all these energy consuming pumps. They use energy so they can transport the electrolytes against the concentration gradient, and that's why we can reabsorb the sodium, excrete potassium, and adjust the hydrogen excretion, and from all those processes take place. And as you can see, because of this, these renal tubular epithelial cells consume a lot of oxygen. They are highly metabolically active, and likewise, they are very susceptible to hypotension and ischemia. So if you have hypotension and ischemia, just like the brain, renal tubular epithelial cells quickly get necrotized. Luckily, if we can restore the volume, after about 7 days, necrotized cells can regenerate. So sometimes, depending on at what stage you are seeing a patient, the same condition you may be seeing, but you may be seeing at two different stages. For example, like Luna Sala gastroenteritis, volume depletion, hypotension, and lare. I mean, I Luna, change so like the recognize low like the solution. Hypotension at the 9 IV fluid go massively pump and low like aggressive fluid resuscitation low like blood pressure bring up low like solution. The renal tubular epithelial cells are necrotized မဖြစ်တော့ဘူးချက်ချင်း oliguria နဲ့ urine output ကလည်း pick up လုပ်လာမယ်ဒါပေမဲ့အဲ့ဒီ hypotension ကနည်းနည်းကြာသွားတယ်ဆေးရုံရောက်နေတယ် drip မရဘူး12နာရီလောက်ကြာသွားတယ်ဆိုရင် due to ongoing hypotension these renal tubular epithelial cells may start to get necrotized. Not the same condition ပဲ gastroenteritis ကနေစတာပဲ hemorrhagic shock ကနေစတာပဲဒါပေမဲ့if you see the patient in the late stage, once the renal tubular epithelial cells have become necrotized, IV fluid the kidney is not going to quickly turn around in a matter of hours. You just have to wait 7 days until the renal tubular epithelial cells regenerate. So when you see the patient, when you work up the acute renal failure, acute kidney injury, it's quite important to be able to differentiate whether the patient is still in a volume depleted state versus already in an established ATN. Because if you are already in ATN, even though it might have started off with volume depletion, if you pump in a lot of IV fluid, the patient will not get better, but instead you might be pushing the patient into pulmonary edema and making the condition worse. So it would be a good idea to be able to decide whether patients still benefit from IV fluids or not. Renal causes in the amplify low solution, those you can read it. Acute tubular necrosis, ischemia is the bulk of the reason, but there can be hypotension. Without any hypotension, you can still get some direct nephrotoxic damage, such as like myoglobin, hemoglobin, urea. Myoglobin or hemoglobin bloodstream cell hemoglobin molecule red blood cell myoglobin molecule muscle damage RBC rupture hemolysis those molecules, if they are released into circulation and if they get filtered, they are toxic to once they get filtered, they are toxic to the tubular cell itself. Likewise, certain antibiotics are nephrotoxic, such as aminoglycoside, amphotericin, certain chemo agents, cisplatin, radio contrast material that is used during the IV radio contrast, of course, poisoning, ethylene glycol, and those things, they are more common in West. Acute interstitial nephritis is due to allergic reactions, so it can happen anytime. It doesn't matter whether how much dose you have sustained. You can get only one dose and develop side effect, or you may have had 4 or 5 days course of treatment, only after which you develop. So it's allergic reaction. Many drugs can cause it. Commonly antibiotics. I will not read it out for the sake of time. You can read it. So now you understand how acute renal failure takes place. Now you understand what are the causes. So this slide is the actual meat of the whole lecture. So the slide ko na le aw shout pi lo pyo nida apo lo mhou bu. So when you come across with a patient with acute kidney injury or acute renal failure at a physician level, how would you manage it? How would you treat it? If possible, you might want to decide whether this is truly acute or there is underlying chronic. It may be hard to tell. Creatinine comparable 6 months ago, a year ago, a creatinine is if not, you may have to rely on history. Sometimes if you can do ultrasound, any type of chronic kidney disease, chronic kidney shrink. If you find a highly echogenic kidney on ultrasound, that suggests chronicity. The reason it's a good idea to decide whether it is acute or chronic is we can tell the patient, for example, like if the patient's kidney failure start to deteriorate and start needing dialysis, a lot of the time patients ask, Doc, I have heard that once you are on dialysis, you have to live with dialysis forever. What's my chance of recovering? If you know for sure that this is entirely acute, for example, like if you have a comparable serum creatinine just from 2 weeks ago on the same patient, which is entirely normal, you can be a little bit more confident in reassuring that, look, Mr. X, Mr. Y, your kidneys were perfectly normal just 2 weeks ago. So I have a feeling that once we can fight through the acute illness, most likely the kidneys will recover. Let's give it a try with dialysis. It's likely to be a short-term need. On the other hand, if you know that somebody's serum creatinine 6 months ago is already 5 milligram per deciliter, patient has 20 years history of diabetes and hypertension and known chronic kidney disease, and by the time when another acute insult takes place, maybe hypotension, maybe MI, maybe antibiotics, and once the patient tips over to the uremic stage, those patients, they are unlikely to recover. So I'm able to reason ule uncle kidney or Nogoria Macau, dialysis this may be beginning of your long-term dialysis. So the patient can decide. Some patient may decide, I don't want to live this kind of life. I'm going to opt out not receiving dialysis and I'd rather die. There are some patients like that. We have to respect autonomy. We have to respect the patient's wishes. So it's good to be able to tell acute versus chronic. And then what I usually do is that I quickly rule out the post-renal causes. How would you do it? Put in a Foley if you have a BPH, obstructive uropathy, distended bladder, urine will gush out, creatinine will come down. You solve the problem. Like I said, bedside ultrasounds, portable butterfly ultrasounds has become very widely available, at least in West. So you can just do a bedside ultrasound and see whether patient has a distended bladder. So that part is easy. And a little difficult part is deciding whether between the renal failure is pre-renal versus renal, because there is some usefulness in being able to differentiate between the two, like I've told you, as regard to timing of the fluid therapy. So how would you do that? Well, let's go back to the basics. You start with history taking. You may have to ask some leading questions if the patient doesn't offer or come upfront, tell you that whether patient has history of volume loss, whether patient has exposure to nephrotoxic agents recently, ibuprofen, aspirin, Buspro, Motrin A, တနေ့9လုံး10လုံးလောက်တစ်ပတ်လောက်အများများတောက်ထားလားဒါကြောင့်ဖြစ်မယ်တော့မဟုတ်ဘူးပေါ့လေ those are the possible culprits. And then you do full physical exam with particular attention to indicators of volume status ဟာ patient က tachycardia ရှိလား orthostatic blood pressure ရှိလား skin turgor ဘယ်လိုလဲ dehydrate ဖြစ်နေလား mouth က dry ဖြစ်နေလား or on the other hand allergic interstitial nephritis ကို suggest လုပ်မယ် allergic skin rash ရှိလား drug exposure ရှိပြီးတော့ and then history, physical and labs, what you would do, urinalysis, you look at BUN creatinine and calculate the fractional excretion of sodium, which can tell the difference between pre-renal versus renal, and also looking at the urine electrolyte. And based on those, sometimes you may not be too sure whether it is pre-renal or renal still. And there is nothing wrong with giving a fluid challenge. Mixed picture. စတော့ကတော့ volume depletion နဲ့လာတယ်ဒါပေမဲ့ကိုယ်စီရောက်တဲ့အချိန်မှာကျတော့ ATN လောက်ဖြစ်နေပြီဆိုတော့တခါလေမသေးကြဘူးဆိုရင် there is nothing wrong with giving fluid challenge. You give fluid bolus maybe about 1 to 2 liter in the 4 hour, but the key is go back and reassess the patient after a few hours. A patient will IV fluid 100 cc per hour တင်ထားပြီးတော့တညလုံးကိုဟောက်စားခြင်းခန်းထဲမှာသွားအိတ်နေပြီးတော့မနေ့ကျမှသွားပြန်ကြည့်ရင်လူနာတကယ်ကို volume depleted ဖြစ်ထားတဲ့လူဆိုရင်တော့ okay ပဲပေါ့ you fix the problem but လူနာ establish ATM ဖြစ်နေရင်မနေ့လင်းလို့ရှိရင်လူနာ pulmonary edema ဖြစ်နေတော့မယ်အဲ့တော့ကိုက aggressive fluid resuscitation ပေးပြီးရင်ဘာတော့လုပ်ရမလဲ4နာရီလောက်နေလူနာသွားကြည့်ရမယ် urine output pick up ဖြစ်လာသလား blood pressure ဘယ်လိုလဲ tachycardia ကျသလားအဲ့လိုပေါ့ကိုပေးနေတာ if you are on the right track then you can continue giving the IV fluid whereas in spite of giving say like 1 liter 2 liter bolus in 4 hours, if there is no improvement in urine output, clinically it tells that it is not volume depletion, then you better stop what you are doing and cut back the IV fluids. And last but not the least, occasionally, in spite of all these clinical and laboratory data, if you don't get to the diagnosis, especially in terms of glomerulonephritis, such as like lupus, rapidly proliferative glomerulonephritis, then we might have to do a kidney biopsy, but it takes a few days for the biopsy to come back. Here are the differential findings between pre-renal versus renal. If you think of it physiologically, pre-renal solution, cell they are damaged, so they are doing their job. If someone, a biological organism, if you are faced with hypotension, volume depletion, how would the body respond? Go back and recall memory from second MB physiology. So, maintaining the effective circulation volume is the key. If you have drop in effective circulatory volume, if you have drop in blood being delivered to heart or brain, you die. So all the living organisms have ways to homeostasis to restore the effective circulatory volume when you are faced with dehydration. If you develop dehydration from gastroenteritis, how the body will be responding in a normal setting. The body will be, for example, like the kidney, it would want to reclaim all the water it can. See ya, concentrate ဖြစ်သွားမယ် see နည်းနည်းလေးပဲထွက်မယ်ဘာဖြစ်လို့လဲဆိုတော့ see ထဲမှာရေတွေမထွက်အောင် body ကပြန်ပြီးစုပ်နေတာ how do you absorb in the body fluid compartment? Again, this is second MB physiology. Body fluid compartment, the water can cross the body fluid compartment easily. The only force that is determining the fluid shift is the osmolality of the compartment. And in human body, 80–90% of our osmolality is determined by the sodium molecule. So if you move sodium, you can move water. That is as simple as that. So that's how the kidneys are designed. If you have hypotension, the kidneys will be avidly reabsorbing every molecule of sodium. So the urine that is made, it may be concentrated, it may be rich with urea, it may be concentrated, but there is very little sodium, because by reabsorbing the sodium, water will follow through. By reabsorbing the sodium and not letting it go in the tubules, water will be following along the sodium and blood pressure will be restored. So by understanding that physiologic concept, you can guess what kind of findings you can expect. So in urinalysis, there is no structural damage. So there will be no cellular cast, maybe a few cellular or granular casts. Specific gravity will be high. Osmolality will be high, but urine sodium will be very low. And if you look at the urea and creatinine ratio in the blood, it is high. Whereas in renal causes, in case of acute tubular necrosis, you will find necrotized tubular cells under the microscope, and they are called muddy brown cast. Sometimes if it is rapidly proliferated glomerulonephritis, you will see RBC cast. And the urine, they may not be concentrated, again, because when the renal tubular epithelial cells get necrotized, these pumps are gone. So the kidney lose the ability to reclaim the sodium. Even if you remain active, it loses such adaptive mechanism. So if you go and look at the urine will be not as concentrated, osmolality will be low, urine sodium will be high. And if you calculate the fractional excretion of sodium, it will be greater than 1, whereas fractional excretion of sodium in the pre-renal is less than 1. It's just another way of looking at how sodium is handled in the urine. So once you identify why the kidney fail, again, I have said it before, there's not much to tell about acute renal failure. Treatment of acute renal failure, acute kidney injury, find and correct the insult. Make sure volume is replete. If you need volume replacement, give it, but don't overdo it. Minimize the nephrotoxin. And if everything goes away, if you can remove the insult, the kidney will go through oliguric phase for about 5 to 7 days, which will be followed by regeneration of renal tubular epithelial cells. So that will be in the oliguric or diuretic phase. But during the oliguric phase, you adjust the fluid that you would give depending on the amount of daily insensible loss, which you can calculate, and adding onto the urine volume from the previous 24 hours. Closely monitor electrolytes, restrict sodium and potassium intake, give high calorie intake so that we don't unnecessarily break down the protein for the body metabolism. The higher the protein breakdown, the higher the urea creatinine is going to be. And last but the least, be cognizant of when to intervene with dialysis. So when we should start dialysis in acute renal failure, acute kidney injury, the indication goes, you can memorize either volume indication or chemistry indication. Volume indication means that patient is in pulmonary edema, volume overloaded, has not responded to diuretics, then a patient is starting to difficult to maintain aeration, then we do dialysis, during which we can remove fluid. And likewise, if you have life-threatening electrolyte and acid-base imbalances, such as severe hyperkalemia, severe acidosis, and another vague definition is symptom of uremia. That one is a little bit harder to substantiate because each and every individual varies in the response, how they respond to elevated BUN and creatinine. BUN of 80 milligram versus 90 milligram, when to start, it's hard to say. But the conventional wisdom is, arbitrarily speaking, at least once the BUN is greater than 100 milligram per deciliter, no nephrologist will argue that dialysis should be started. Between 80 and 90, it may depend on many other conditions. And if you see other signs of uremia, such as like uremic serositis, like pericarditis, pleuritis, encephalopathy, those generally, in my experience, you find it only in a quite late stage of uremia if you wait till like BUN is about 200. So at least in West, we do not see these kind of severe uremia textbook descriptions because we rely a lot on the blood chemistry. There is some school of thought think that, early initiation of dialysis will hasting the recovery, but something that no unnecessary procedure, unnecessary intervention, having to put in a dialysis catheter, and in the long run, it doesn't change outcome. And every 10 years, the pendulum goes back and forth. The literature changes, so I will not spend time much on that. So this seems to be the only slide I have to tell related to COVID-19. So acute kidney injury or acute renal failure in COVID-19 infection, yes, it is quite common. In my experience in America during the COVID pandemic, almost all of the acute kidney injury, acute renal failure you find in COVID-19 infection is not because virus itself affecting the kidney. It is due to the consequences of other multi-organ failure. Patients got into shock, patient get into hypotension, patient was giving many nephrotoxic drugs, antiviral antibiotics, developed necrosis, and hemodynamic shifts. So it is primarily hemodynamic and nephrotoxicity of the medication and agent used in investigations, such as like intravenous contrast dye used in multiple CT scans. And there is very little evidence that virus directly affect glomerulus or tubular cells. So I hope that by understanding how to tackle acute kidney injury in general, that will also automatically, arm you enough how to deal with acute kidney injury in the COVID-19 infection. Little brief 1 or 2, 3 slides of peculiar acute kidney injury syndrome. Hepatorenal syndrome could be quite common in Burma because of cirrhosis of the liver from prevalent hepatitis B and C infection, right? So hepatorenal syndrome, people who have hepatic insufficiency, liver cirrhosis, without good explanation, shock machine, hypotension machine, kidney like fail. It's a diagnosis of exclusion. You have to first make sure that patients are not volume depleted. You have to make sure that patients do not have occult sepsis or infection, or were not exposed to nephrotoxic agents. But after you excluding those, and if someone with advanced cirrhosis develop acute kidney injury, that is by method of exclusion, it is hepatorenal syndrome. It's not a good prognosis. We do not have a good way to treat it, supportive care. If the kidneys fail, we can consider offering dialysis, but we are reluctant and we don't like to, because the finding is that unless the liver improves, which is only possible by getting liver transplant, the kidneys will not improve. So if someone is likely to be marked for liver transplant, we may offer it. And once you get the liver transplant, surprisingly, kidney failure go away as well. So it's a lot functional in nature. There seem to be a lot of hepatic, intrahepatic circulation and the renal circulation. So those hepatorenal syndrome patient, acute renal failure, cirrhosis ရှိတဲ့လူတွေ liver transplant ရလို့ရှိရင် acute renal failure လည်း automatically corrected ဖြစ်သွားတယ် They don't need a liver transplant. They no longer need the dialysis. So here are the definition. Radio contrast induced nephropathy. It is by 2 mechanisms. Number 1 is due to direct nephrotoxicity, just like gentamicin, aminoglycoside. Yes, no doubt radio contrast is nephrotoxic, but the second mechanism is it causes intense vasoconstriction as soon as it hits the bloodstream and gets into the kidney. And lastly, the kidney has to be vulnerable. Now, you don't get contrast material nephropathy in a healthy kidney. For example, like if I develop, just for an example, if I develop a kidney stone attack tonight, and if I have to go to emergency room tonight, and if the ER doctor says, hey, Dr. Wu, I think you have kidney stone, I want to give you a IVP, or I want to give you a CT urogram to find out, knowing that I have normal kidney function, I would not be worried about myself developing radio contrast nephropathy, acute kidney injury. I would say to the ER doctor, yeah, go ahead, I'm not worried about. And 99.9% we get by fine. But people who have vulnerable kidney, by definition, serum creatinine is already high. Patients who are in a volume depleted state, in early shock, if you expose them to contrast because of these 2 mechanisms, you can develop radio contrast nephropathy. Heme pigment induced acute kidney injury may have some relevance in the malpopulation. Heme pigment is a combined term that is used to call both hemoglobin and myoglobin. Myoglobin is from muscle damage. Muscle damage can be either traumatic or non-traumatic. Sometimes certain medication may cause muscle damage without any trauma. Hemoglobin is due to hemolysis. Peculiar in Myanmar, snake bite and malaria would be the leading causes of such kind of heme pigment-induced acute kidney injury. We may call it as black water fever. We explained about the mechanism of the acute kidney injury. These molecules that should not be circulating in the blood, if they get released into the blood and filter from the glomerulus and get into the renal tubules, they are directly nephrotoxic. They can plug up the tubules, can also promote vasoconstriction. Another mechanism is snake bite, especially as you all know, Viper series. By virtue of hemolysis, they can lead to DIC, coagulopathy, hemolysis, or even rhabdomyolysis, and sometimes hypotension and shock. The treatment is, as we have covered, supportive care for acute kidney injury, give antivenom, and of course, when the kidneys, completely fail, would benefit from dialysis. Severe malaria, especially from Plasmodium falciparum infection, you get hemolysis because of that, and hemoglobin is released, and they are nephrotoxic. Not only from direct nephrotoxicity, the malaria parasite itself seemed to have contributed to impairment or occlusion of renal microcirculatory flow in some experimental studies. So anyway, that's the reason. So these will be relevant to Myanmar population, why you may develop, renal failure, acute kidney injury without having had to have hypotension, blood pressure, low. This is direct nephrotoxic damage. Aminoglycoside nephrotoxicity, again, there are risk factors. Not everybody get it. People who are more predisposed to aminoglycoside nephrotoxicity, it depends on the dose and duration. It's a dose-dependent phenomenon. Aminoglycosides, they are filtered and reabsorbed in the renal tubular epithelial cell. And eventually, when the intracellular concentration of aminoglycosides start to get high enough, it causes damage to the cellular organism. So aminoglycoside nephrotoxicity, characteristically, you don't find it on the day one. It takes 4 or 5 days before you start to see it. If you start someone on gentamicin today, and if that individual develop oliguria and renal failure tomorrow, you better search for another explanation. It is not aminoglycoside nephrotoxicity. It is dose and duration related. Patients who have underlying hypokalemia are more prone. These are common sense. Older individual, those who have reduced effective circulatory volume, pre-existing renal disease, they are more prone to get. Among the available aminoglycoside, gentamicin is the worst when everything else is equal, of course. Tobramycin is the least nephrotoxic aminoglycoside, and amikacin is in between. So it is caused by accumulation in the renal tubular epithelial cells, usually 5 to 7 days into antibiotic course. Generally, it is not densely oliguric, and if you look at the urinalysis, not many active sediments. And good thing is that if you stop the antibiotic, if you recognize this early enough, it is quite likely reversible. So that ends my lecture, and I think that I exceeded a little bit. It's 10:48, so I can open the floor for questions, or we can go over the earlier questions again to see why people chose which particular action and whether you get it right or wrong. မေကွန်းမေးဆရာမိုးကျော်ဟိန်းဘယ်လို format လုပ်ချင်လဲမေကွန်းမေးမလားဒါမှမဟုတ် question လေးတွေသွားမလားအချိန်တော့နည်းနည်းတော့ကြော်သွားပြီ
ဟုတ်ကဲ့ဆရာဟုတ်ဆရာမေကွန်းဒီနေ့အတွက်ဆရာအချိန်နည်းနည်းလေးဆရာရရင်တော့မေကွန်းတချို့နည်းနည်းအနည်းချင်းတော့ဆရာပြောပြပေးလို့ရမလားဆရာသူတို့များရှိဆရာမ
I have no problem I have no time limit it's just on the audience yes
ဟုတ်ကဲ့ပါဆရာဟုတ်တကယ်လို့များမေကွန်းများရင်တော့လည်းမနှက်ဖန်ချက်ဟုတ်ကဲ့ပါ
question လေးတွေသွားလိုက်ပြီးတော့ခုနလည်းဖတ်ပြီးပြီဆိုတော့နော် question လေးတွေသွားပြီးတော့အဖြေမှန်လေးတွေကိုပြောပြလိုက်မယ်ပြီးလို့ရှိရင်ဒီ based on this topic any question from the audience will be open so the problem number 1ကကျမ်းမြင့်ကပေါ့နော်ဒီ85နှစ်ရှိတဲ့အမျိုးသမီးကြီး retire nurse တခြားမျိုးကနေရွှေ့လာတယ်သူမှဟလာ down hypertension or osteoarthritis to she hypertension she or hydrochlorothiazide or synthroid or barotau needed. Comio piang lare, Lara Bale, so down the just say you tattoo people where selling or take the garden Georgian Bamale Maluchimbu, Eradame, selling Ale, Madrid Luna, this or we calculate or serum creatinine, no, the same she serum creatinine at 1.4, blood pressure is okay, weight 105. So one thing I have to admit is these questions are from the West. So 105 in my population, it's okay. But in the Caucasian, 105 is quite low. Small body mass to I should have made the question a little more clear, make it like the weight is 75 pounds. So otherwise, in Myanmar population, 105 would be okay. But in West, a lady 105 pounds would be considered, a little bit low weight. And she just doesn't want to spend much time. So long as she keeps her pap smear and mammogram, down the say like I mentioned that her renal function is slightly abnormal, but hey, not too bad. We check serum creatinine a year. Or tell that creatinine of 1.4 in elderly women with low body mass is significant, and you better run a few additional tests to find out what kind of chronic kidney disease you have, or order fractional excretion of sodium. So the correct answer is number 3. The reason is this signifies the significant impairment. First of all, fractional excretion of sodium is useful only in acute renal failure workup. There is nothing to state that this lady has acute renal failure, so this is totally out of it. But the other two, they go in the same direction. If you calculate the creatinine clearance of this lady using the given laboratory data, that shows creatinine clearance is only 26 mL per minute. The kidneys are working only 26%. And based on the prior records, this is chronic renal failure, not acute. And so just to emphasize the point that if you just look at the snapshot raw number of creatinine, you could miss certain percentage of chronic renal failure patients. So the correct answer is number 3. Number 2 question, just to quickly give a synopsis, this is a previously healthy young Latama carpenter come in with fever, rusty sputum, leukocytosis ရှိတယ် tachycardia ရှိတယ် blood pressure လေးက 90/45 ဆိုဖုတ်လိုက် chest x-ray မှာလည်း infiltrate တွေရှိတယ် leukocytosis ရှိတယ် BUN creatinine ကနည်းနည်းလေးတက်နေပြီ နောက်24နာရီကြာတဲ့အခါမှာဆိုလို့ရှိရင် preceding night မှာ urine output low ဖြစ်တယ် blood culture လည်းရောက်တဲ့နေ့ကဖောက်လိုက်တဲ့ဟာမှာ gram positive cocci growing with the clinical presentation like that, it's likely to be pneumococci pneumonia and pneumococci bacteremia, and likewise BUN and creatinine has significantly gone up. So what would you do? The choices are okay, urine show specific gravity, this is high, consider ketone positive, blood negative, no significant RBC cast, WBC cast. So what are your diagnosis and management? Number 1, aminoglycoside nephrotoxicity and stop gentamicin. That is incorrect because you started gentamicin only the night before. Number 2 is post-infectious glomerulonephritis. Check complements and continue current antibiotics are for now. It is possible, but not exactly in this scenario. The reason is glomerulonephritis, post-infectious glomerulonephritis ဆိုပြီးနေဆိုလိုက်တာနဲ့ဟုတ်နေတယ်ဟလာ strep pneumonia infection bacteremia တော့ဟုတ်တယ်ဒါပေမဲ့ urine pattern က glomerulonephritis pattern မဟုတ်ဘူး blood negative no active sediment, no RBC cast, so this is not compatible with glomerulonephritis. Number 3, order 24 urine protein and creatinine clearance. This is incorrect. ဘာလို့မှလဲအဲ့ information ရလို့လဲဟလာ protein urea ရှိတော့ဘာလို့မှလဲ it has no relevance to management. Number 4, give volume resuscitation by aggressive IV fluid, normal saline, 200 cc per hour. And this is the correct answer. If you go back and look at it, patient borderline hypotension, as you can see, a little bit tachycardic, blood pressure is borderline low, and then patient developed bacteremia. So what happened in sepsis? Vasodilatation ရှိတယ် to get true blood loss to volume loss to မရှိတော့မှာ due to vasodilatation, the effective circulatory volume in relation to amount of blood available is getting low. Right? Or capacitant vessel တွေက vasodilate ဖြစ်သွားတဲ့ခါကျတော့ hypotension ပိုတော့ဆိုးလာမယ်။ပိုးလာတဲ့အတွက်ဒါပေမဲ့ကြည့်ရတာက ATN stage ကိုမရောက်သေးဘူး urine မှာက highly concentrated urine, no tubular cell cast. Of course, urine sodium တို့ဘာလို့ပေးရင်တော့ပိုသေးကြတာပေါ့ကိုတကယ် electric မှာဆိုရင်တော့ you will order urine sodium fractional efficient sodium, but clinically this fits with patients who are in a state of volume depletion. So this is the correct answer, fluid resuscitation ပေးရမယ် Number 5, sepsis induced ATN prepare for dialysis in the near future. We are not there yet. Nothing to indicate hyperkalemia, fluid overload, nothing to indicate, and clinically it is still in volume depleted state. So the correct answer is number 4, fluid resuscitation. Okay, last question. That is a college student, track and field, emergency room or lare. 1 day history of flu-like symptoms, sore throat, temperature 100, urine lysis normal except 3+ protein. So what are the possible causes? Treat as post-infectious glomerulonephritis. Again, the clinical scenario may be, yes, post-streptococcus glomerulonephritis, but urine has nothing to indicate it is glomerulonephritis. By glomerulonephritis, you would expect RBC cast and active sediment. Urine only have 3+ protein. So this is what you call as nephrotic pattern protein. Nephrotic syndrome or nephrotic pattern protein, not a nephritic pattern. Collect AM and PN24 urine collection for protein. There is a term called orthostatic hypotension, which is a physiological variant. You have more proteinuria in the upright position. So if you go and collect the overnight urine collection and measure protein, there is very little protein, but another 24 urine you may have higher protein. So sometimes if you don't have any other explanation to reassure patient that this is the physiologic, sometimes you can do that. But this patient has, fever, symptoms, so those do not fit. Number 3, collect 24 urine and protein creatinine clearance to determine the severity of the condition. Yes, it may be used for 3+ proteins or 2 gram, 3 gram. It's not the best answer in the scenario. Number 4, retest urine analysis once acute illness is over. And this is the correct condition, the answer, because transient proteinuria is common after certain physiological activities such as strenuous exercise, febrile illness. If you have run a marathon and if you go and measure the urine protein of the marathon runners, even though they are the fittest individuals in the world, marathon runners, they may have some protein. Or if you come down with the flu, illness during that time, any type of febrile illness. But the thing is, those situations, once you go and recheck it, proteinuria should go away. Number 5, so number 4 is correct. Number 5, proceed with kidney biopsy suspecting minimal change. It is too premature and too aggressive. So these are the conditions. So that ends my lecture and the questions. So anyone, if you have any questions, I will stop sharing the screen. Anyone, if you have any question, I'll be happy to answer. Like I said, I do not have a time limit. I can stay on as long as you want to stay. Thank you.
Chat box မှာလေကျွန်တော်တို့ question လေးတစ်ခုရောက်နေပါတယ်ခင်ဗျဆရာတွေ့ရလားခင်ဗျ
What is the maximum dose of furosemide in chronic renal failure? Yes, that exact topic will be covered tomorrow when we talk fluid and electrolyte balances and correct use of diuretics, but I can answer it right now. The reason we have some concern in high dose furosemide is due to ototoxicity, right? Everybody knows loop diuretics, if you use too high a dose, you can have ototoxicity, permanent hearing loss, so that can be the case. On the other hand, the dosage of loop diuretics that one has to use may be different based on the clinical scenario. There are certain situations which has diuretic resistance. So normal healthy kidney မှာ 10-20 mg လောက် furosemide ပေးလိုက်လို့ရှိရင် risk diuresis ရတယ်ဒါပေမဲ့ patient chronic renal failure ရှိလို့ baseline creatinine က 3 to 4 mg လောက်ဖြစ်နေပြီဆိုရင် 20 mg လောက် furosemide နဲ့ touch မလုပ်ဘူး So to make the long story short, I would say I would not use, regardless of no matter why you have to use high dose furosemide, I would not use more than 400 milligram per day of furosemide a day. That will be about the maximum. And tomorrow there will be some little more detailed coverage of correct diuretic usage and the common pitfalls. So tomorrow's lecture is about fluid electrolyte balance and correct usage of diuretics. So we shall cover that tomorrow again.
ဟုတ်ကျေးဇူးပါဆရာဟုတ်ဆရာတို့ဆရာမတို့မေးခွန်းလေးရှိရင်ဟိုဒီနေ့အနေချင်းတော့မေးလို့ရပါသေးတယ်ခင်ဗျဟုတ် chat box ကပဲဖြစ်ဖြစ်ကျွန်တော်တို့ unmute လုပ်ပြီးတိုက်ရိုက်မေးရင်လည်းရပါတယ်ခင်ဗျအဆင်ပြေပါတယ်ဟုတ်
hello ပြေးကျင်နေကြတယ်ဆရာတို့ကျောင်းသားတော့ဆိုတော့မိကမေးစရာဆိုမရှိဘူးပြေးဖို့ပဲကြံနေတာပဲလားခုအများစုကဒါဟွာလာဒီ junior doctor NGO လာ covid ဟို telehealth ဆရာဝန်တွေလာဖိတ်ချတော့မမေးလိုက်ရဘူးဒီ audience က
ဟုတ်ဟိုအစုံပါပါတယ်ဆရာကျွန်တော်တို့ NGO ကဆရာမတွေပါတယ်ပြီးတော့ဟိုကျွန်တော်တို့ telehealth လုပ်ပေးနေတဲ့ teleconsultation လုပ်ပေးနေတဲ့ group ကဆရာမတွေပါပါတယ်ဆရာပြီးတော့ GP လုပ်နေတဲ့ဆရာမတွေလည်းပါပါတယ်ဆရာဟုတ်ဒီတစ်ခေါက် group ကအစုံပါပါတယ်ဆရာဟုတ်ကဲ့ဟုတ်ကျေးဇူးပါဆရာအခုတော့ question လေးတွေမရှိကြတော့ဘူးနဲ့တူပါတယ်ဆရာမတွေအနေနဲ့လည်းဟုတ်ကဲ့ဆရာကိုလည်းကျေးဇူးအများကြီးတင်ပါတယ်ခင်ဗျ
not at all I hope that is useful okay
ဟုတ်ကျေးဇူးအများကြီးတင်ပါတယ်ဆရာအကျိုးရှိပါတယ်
အဲ့ဒါဆိုပြန်တစ်ခါတွေ့ကြမယ်လေ
ဟုတ်ကဲ့ပါဆရာဟုတ်
okay good night everyone well good morning over there
ဟုတ် good night ပါဆရာတော်ဟုတ်ကဲ့ပါဆရာဟုတ်ဆရာတို့ဆရာမတို့အားလုံးလည်းကျေးဇူးအများကြီးတင်ပါတယ်ခင်ဗျဟုတ်ကဲ့ပါ
okay bye bye okay
ဟုတ်မနက်ဖြန်မနက်7:00 နာရီမှာပြန်တွေ့ပါမယ်ခင်ဗျဆရာရဲ့ lecture day 2 ထိရှိပါတယ်ခင်ဗျဟုတ်ကဲ့ပါဆရာတို့ဆရာမတို့